Today, I'm just thrilled to introduce my boss, but more than that, my mentor and friend, Dr. James Vanderploeg, who so graciously agreed to do this talk today because I wasn't going to be here. But so I'm thankful to be back to introduce you, Dr. Vanderploeg. Dr. James Vanderploeg has over 35 years of experience in aerospace medicine with a career spanning space medical support from the beginning of the shuttle program to now serving as Chief Medical Officer for Virgin Galactic. And he is has an active clinical practice in civilian aviation medicine. He is Professor of Aerospace Medicine and Director of Clinical Preventive Medicine, the Department of Preventive Medicine and Community Health at the University of Texas Medical Branch in Galveston. Among his responsibilities are serving as the Executive Director and Principal Investigator on multiple research projects of the FAA Center of Excellence for Commercial Space Transportation, evaluation of airline pilots seeking special issuance authorization of medical certification following recovery from medical or psychological problems, and training physicians in the specialty of aerospace medicine. As Virgin Galactic's Chief Medical Officer, Dr. Vanderploeg is responsible for developing and implementing the medical programs for spaceflight participants, Virgin Galactic pilots, and other employees. Dr. Vanderploeg is a past president of the Aerospace Medical Association, not the American Medical Association, the Aerospace Medical Association, more important than that, the AMA, the other AMA, and current chair of the Fellows Group. He's also an FAA Senior Aviation Medical Examiner and is board certified by the American Board of Preventive Medicine in both aerospace medicine and occupational medicine. He has numerous awards and publications, the most recent being the medical results from research projects using centrifuge exposure to simulate the G-forces of the Virgin Galactic spaceflight. Dr. Vanderploeg.
Well, good morning, and thank you, Tara, for that kind introduction. Each month, I much prefer to be sitting where you are than doing what I am today, standing up and talking with you. But what I hope to do this morning over the next hour is to take you through a bit of a journey, the journey I've been on for the last 10 years in my career. It's been one that the previous 25 or 30 years, I think, has helped me prepare for, but it's certainly a changing environment as we get involved in commercial space flight support. So what I put up here is an outline of what I'm going to touch on. I'll probably spend most of the time on numbers 5, 6, and 8 as we go along. But I want to try to cover what it's like to be involved in support of commercial human spaceflight and what some of the differences are that I've encountered along the way. First of all, just some acknowledgments. The name on the top, Dr. Richard Jennings, is key as he set the foundation and the groundwork for supporting human commercial spaceflight with his work with Space Adventures and the billionaires who fly to the ISS, and has been a true friend and mentor to me as I've undertaken this path. Tara Castleberry and Chuck Mathers and Becky Blue have been very helpful and supportive and continue to be involved with this work as well. I didn't list all of our residents by name because there's a whole bunch of them, but they've also been very helpful to me in challenging assumptions and keeping me on my toes. Our funding for much of the work that I'm going to talk about under the research topic comes from the FAA's Office of Commercial Space Transportation, from NASA Educational Grant and the NSBRI and now TRI funding. Another source of tremendous help has been the Virgin Galactic Medical Advisory Board, a group of physicians that have met a number of times over the last 8 or 9 years and really ask the tough questions and help guide and direct the work that we're doing in trying to put together a medical program for a new endeavor. And last but not least is the NASTAR Center, where is located the centrifuge that we use for much of our research. And they have been tremendously helpful because they basically give us the use of the centrifuge for free or nearly free. And we could not have done the work we've done without their support. So what do we traditionally think of as a flight surgeon? We tend to focus on the flight crew, the pilots and folks in front, because up until now, other than with the rare exception, there haven't been any folks in the back. There haven't been the passengers that are flying just because they want to and can afford to. And so our work has very much been focused on the flight crew and the ground support team. And in that work, we deal with medical qualification and certification. There are sets of standards and procedures already in place. We follow those. We make decisions about up or down, about waivers or not, and so forth. We're involved with the crew medical care, both on the ground as well as in flight, and also participate in the planning and preparation for emergency response. We get asked questions and provide input on life support equipment, environmental control systems, and many other things. None of this is new to you. But what's different now? Well, quite a few things. The relationship with the flight and ground crew is different than it is in a government organization. There's a lack of medical standards against which to evaluate people, particularly the passengers. Folks that buy a ticket may do so 10 or more years before their flight. And when at the point that they put down their deposit on a ticket, there is no medical screening. Anybody can do that. So that presents some challenges. It's a whole new medical legal world for those of us that are involved, in that practice. Let's see here. There we go. So I'll talk a little bit about that. Commercial flights operate under a different environment than government flights do, and I'll talk about the concept of informed consent and what that means and implies. The folks that we're flying are not your typical size, shape, age, or medical status, but they're also folks that don't understand that little two-letter word, no. They want to hear, yes, you can go. Just to touch on the flight surgeon support for flight and ground crews, I tend to think of three broad categories of the flight surgeon, flight crew relationship. The military model, flight doc is part of the squadron. You live, eat, breathe, and sleep with your team, and as a flight surgeon, you make the decisions about up chits and down chits. Yes, the commanding officer can overrule you and say, I don't care, doc, this guy's going to fly today, but that doesn't happen very often. The NASA model, in my experience, is quite similar to the military model, even though we're a civilian organization. And what I call the civilian model is really the FAA AMEs, the folks that are taking care of civilian pilots, and many of you have done that as well. I think what we're seeing in the commercial human spaceflight world is really a hybrid that's a mix of all of those. And although the company employs the pilots for the most part in most of the companies where they're flying their own type of flights, not a NASA flight. The regulations that apply are FAA standards. The pilots only have to meet a Class 2 FAA medical standard, which is pretty minimal, especially if you're taking folks to space. And so it is a bit of a cross between a civilian and a military model, and that presents some unique challenges as well. I put this up just as kind of an overview of what I've been privileged to be involved with over the last 10 years. It's really starting from scratch. You're asked for input on cabin design and seat design and restraint systems. How do you design a seat and with adjustments that will fit a 4'8", 80-pound individual or a 6'6", 300-pound individual? That's quite a challenge. That's restraint systems that hold them in place. Pear-shaped people don't exactly fit the same mold as tall and skinny people. Environmental control systems. What are the requirements? What are the parameters? Are there going to be pockets of CO2 that accumulate, and how do you deal with that? How do you get people out? What should the crew selection be? When we hire a new pilot, what do we need to know about them? Emergency response preparations. For the most part, commercial spaceports are not located in large metropolitan areas. At least the ones I've been dealing with in Mojave and Spaceport America in New Mexico, you're a long ways from level 1 trauma centers and definitive medical support. How do you keep track of things? At least I haven't been able to find an off-the-shelf electronic medical record that's specific for space flight. So we've had to develop our own and kind of retrofit existing products. And the last one there, passenger medical risk and assessment and training for that. So I'm going to touch on many of those things as we go along today. One of the challenges that I've been working with over the past 10 years is passenger medical assessment and acceptance. The spaceflight participants, the customers, passengers, whatever term you want to use, many of them come with significant medical histories and ongoing medical conditions that could impact on their personal safety. As I mentioned earlier, we have a lack of standards. There are no standards set by the FAA. There's a number of guidelines that have been put out by the FAA, by Aerospace Medical Association, by the Center of Excellence for Commercial Spaceflight and other groups, and they're all very helpful, but they're, again, guidelines, not standards. And so for the most part, what matters is what the company and the passenger are willing to do. Under FAA regulations in the U.S., there's an informed consent process, and I'll talk more about that to address the acceptance of risk. So with that background, what is the evidence base for being able to expand access to space and making space available to a much broader segment of the population? When I started, we really had very limited information, and it was all based on either military or NASA experience with people who tend to be younger, much more healthy, very fit than the folks that I was seeing starting to walk in the door. And over the last 10 years or so, we have evaluated in an acceleration profile using the centrifuge at the NASTAR Center, 3 main groups of people. The initial group was a group of the Virgin Galactic founders back in 2007 and 8. Then a research project that I'll spend some time talking about that we finished up in 2014. And then most recently, work that we've completed all of the data collection and are still in data analysis, and publication submissions are underway right now. But in total, that is about 320 people that we put through a spaceflight profile. So that's a significant number. And I'm going to touch on some of those things that we've done to develop that evidence base to say, yep, I think you're good to go. The first study that we did as a research study in 2013 and 14, we wanted to look at individuals with defined medical problems, and there were 5 categories that we looked at: heart disease, high blood pressure, diabetes, pulmonary disease, and folks with neck and spine problems. And the results of that were published in 2014. The reference is up there on the screen in Aviation, Space, and Environmental Medicine. And there were several other 5 or 6 additional papers that addressed various components of that research project as well. And what I want to just briefly touch on kind of top-level findings out of that. We recruited volunteers based on their suitability and fitting into one or more of the 5 disease categories, as well as a control group. The stimulus was centrifuge runs, two days, 7 runs over those 2 days. The first day was 2 GZ runs, first at 1.7 G and then at 3.5, with sustaining that for 15 seconds, both in the Z and then in the X direction. And then day 2 was a simulated space flight using the actively controlled gondola to combine GZ and GX, and with peaks at 6 GX and 4 GZ. And what we collected in that was blood pressure, ECG, pulse oximetry, pre and post spin neurovestibular exams, and post-run questionnaires asking about a number of things, including things like motion sickness, disorientation, gray out, anxiety, and other symptoms. Just quick breakdown of how the various categories ended up. Fortunately, we had sufficient volunteers that we achieved the power that we were looking for in terms of statistical analysis in all the groups. The smallest group was the diabetes group with 9 test subjects. One thing I learned that I didn't expect is it takes about 3 or 4 volunteers to get one that actually gets through to the bottom. We had 335 folks that registered their interest in being test subjects, and we ended up spinning 86. So this becomes a logistical challenge when you're doing this kind of work, especially when it's not local. The centrifuge is located just outside of Philadelphia, and all these folks had to get there, and we didn't pay them to get there. So they had to volunteer and travel on their own if they weren't local to the Philadelphia area. We required an EKG on everyone. We didn't disqualify anyone based on what their EKG looked like, and some of them looked pretty interesting. And no surprise, high G acceleration is arrhythmogenic. Over 50% had some rhythm abnormality during their centrifuge runs. Most of those were PACs or PVCs. We had folks that showed bigeminy, trigeminy. One individual had a 7-beat run of VTAC that resolved fortunately on its own. And when I left the house this morning, she was still alive and well. Yes, that was my wife, and she was a control subject. And 6% with sinus dysrhythmias. One area that was a bit of a surprise and led to a follow-on study that I'll address in a moment was the folks that had some significant anxiety to the point of actually disrupting the flow of the testing. And that got our attention, because if you have that during or just prior to a space flight, you don't want that to happen, and you sure don't want it to happen 2 seconds before launch and somebody decides they don't really want to be there. And so when it's severe, it requires a significant amount of attention. We were very unsuccessful on predicting who might fall in that category, and so we looked at a follow-on study to try and address that. If you have a bit of hypertension, it's helpful. It reduces your risk of gray out, and as long as it's well controlled and it doesn't shoot through the roof, being a bit on the hypertensive side is actually better than being hypotensive to start with. Heart disease. This was our major concern going in, thinking, we've got a lot of folks who are in their 50s and 60s, and atherosclerotic heart disease tends to develop. We spun people who had pacemakers, histories of infarcts, stents in place, previous cardiac bypass surgery, heart valve replacements, one tetralogy of flow after surgical correction. So we didn't pick just easy cases. And fortunately, they all did very well. And so that made us feel somewhat better about being able to fly individuals with significant cardiac disease history. Diabetes was another area of concern, since there was no prior data that we could find on spaceflight and folks that were diabetic. We did have one adverse event. It was an individual who was on oral hypoglycemic agents. He took his pill the morning of the centrifuge flight, but was running late and didn't eat. And so during the spin, he got hypotensive and diaphoretic, and we were wondering whether we were looking at the cardiac problems. Stopped him, evaluated him, everything was fine, and fed him, and he was good to go. And he completed the runs later that day and the following day. But it does get your attention when that happens. And it didn't seem to matter what the level or the method of control of the diabetes was. We flew a couple folks who had insulin pumps, people on injectable insulin, folks with oral agents, and folks that were controlled just by diet alone. In the pulmonary arena, we did not have anyone with COPD per se, because nobody with that volunteered. We had a number of folks with histories of asthma, some quite severe and on current treatment, not just prophylactic. Individuals with organic disease like beryllium disease and interstitial fibrosis. And again, they did well. What we did see is an increased incidence of coughing during the high G runs. Not sure whether that was acceleration atelectasis or what, but we did notice that, that symptom. Individuals with back and neck pain, we had quite a variety of folks that volunteered. Degenerative disc disease, disc herniation, prior surgery. We had a couple of individuals who complained of back strain while doing or following the anti-G straining maneuver. All of those resolved quickly. And we also observed that folks with a history of low back problems had more difficulty performing the anti-G straining maneuver correctly and effectively. And in questioning them, we think that was because they knew they had back pain, they knew that's why they were there, or they had a back pain history, and so they were reluctant to strain as hard as maybe they would have otherwise. But in no case did we have anyone who developed A-lock or G-lock during the high G level. Overall, our conclusions were that folks with well-controlled medical conditions are probably a reasonable risk, and they can tolerate the acceleration profiles quite well. Anxiety was a finding that we wanted to deal more with, and so we did a follow-on study. We just completed June of last year, and as I mentioned, we're still doing final data analysis and getting publications ready to submit. The first one has been submitted and is in review right now. But we were trying to address the question of anxiety. My ideal outcome was we would find some magic combination of questionnaires and evaluation techniques that would predict who is going to be a problem case, and we could then address that. I'm sorry to say I did not achieve that. But it's important to understand, I think, what some of those concerns are, and primarily through training and different training techniques to mitigate that and to alleviate the risk of anxiety. For this study, we ended up with 156 subjects, big number, and yeah, it took about 4 times that number to get down to 157, so there's a lot of folks that volunteered at the beginning. 29 of those we identified as concerning for anxiety and poor tolerance. 10 folks dropped out or opted for not completing the full set of centrifuge runs. One finding, again not surprising, is that the most successful training techniques, as part of the study, we weren't just looking at anxiety per se, but we had people divided into 4 different levels of training prior to their centrifuge runs. Everything from minimal training, in which we basically said, here's how you do an anti-G straining maneuver and here's where the exit is, now go spin, to a full up, pretty intensive relaxation training techniques, and 2 categories in between. And those who experienced the most high fidelity and repeated exposure did the best. So not surprising, but training does help. And a proper approach to the training, I think, is an important thing to develop. The other thing that was a bit surprising is that we asked people about how they felt and so forth in face-to-face interviews after the spins, during their flights or spins and so forth, and then anonymously after the fact. And even though these research subjects that had no effect on anything other than their own pride, we got more reports of anxiety-related symptoms in the anonymous reporting after the fact than anywhere else. So again, something to keep in mind. So with all of that, some of the what I call myths that we're been beginning to dispel are some of these. There is no upper age limit. You have to be 18 to sign informed consent, but we've not said you can't be older than X, which is probably a good thing. We have one individual who's 96 in the customer base. We thought that the use of beta blockers for hypertension might be an issue in terms of suppressing ability to increase heart rate in response to the G-forces. That has turned out not to be the case. We've spun quite a few people on beta blockers. Heart disease is not necessarily disqualifying, neither is diabetes. History of mental illness is not medically disqualifying automatically either. We have had and spun people with history and treatment for bipolar disorder, for depression, for anxiety, and interestingly, those folks did not predict who experienced the anxiety. In fact, they did better than many without that history. And physical disabilities are not necessarily disqualifying, which is also a good thing, because in the customer base we have people with artificial limbs, with multiple joint replacements, who don't bend and stoop as readily as they used to. And I put this picture up to remind myself to talk about kind of the extreme end of physical disability. Professor Stephen Hawking, I was privileged to be on this zero-G flight now almost 10 years ago. And the question I often get is Stephen Hawking really going to fly in Virgin Galactic? I don't know the answer to that. Richard Branson would love to make that happen for him. And we have some ideas on how we might be able to do that, but that's a long way off yet. The other thing that we've been dealing with is the medical screening for spaceflight participants. As I mentioned, there can be a long delay between when they first say, yep, here's my money and I want to go fly, to the time when a flight might actually happen, since we're still not there yet. And in that interim, life happens. People get cancer, people get heart disease, people have onset of new medical problems, and their medical status changes. And so certainly from the company's point of view, you do not want a last-minute cancellation. Flying an empty seat is really expensive. And so ongoing medical status updates become a significant part of enabling a successful spaceflight program for the average customer. Another challenge is, I always tell the engineers I work with that humans are the most complex subsystem of their spacecraft and the most unpredictable. And yes, they ask me for a number. What is the level of X that we can tolerate? Well, the answer is usually, well, it depends. It depends on lots of things, because not everybody is the same, and they're not the same size and shape and weight. They don't have the same G tolerance. They come with different sets of underlying medical conditions. There's cultural differences. There's language differences that get in the way. So it makes life interesting. Put this slide up just to give you a sense of who the customers are. This is a bit dated, but I don't think it's changed much from the Virgin Galactic customer base that I have some information on, which is about 350 out of the 700 who are on the books. Age range, yes, we do have some future flyers who are under 18 because grandmother bought them a ticket for their birthday or whatever. But 18 is the minimum age to fly, and we go up into the 90s. Average age is around 55. They're small to big. The 80-20 distribution between male and female has remained quite consistent over the last 10 years, and it's still there. And I'll talk a bit about the risk ratings and how we've gotten to those. But the important thing from a business point of view is what we call the red risk. That's those folks that we say, you know what, you should spend your money somewhere else. We're going to give yours back because we don't want to take the risk to fly you, is a really low percent. And what kind of problems do they have? Pretty much everything that you would expect to see in that age distribution. High blood pressure, heart disease, diabetes. Things should start to sound familiar because it was out of this base that we picked the 5 conditions that we did that research project on. Folks have allergies. Well, who cares about allergies? Well, you do if you're going to feed them for 3 or 4 or 5 days. What food allergies do they have? You're putting them in a different environment than they've come from. And yes, there are various pollens that occur out in the desert that people have not been exposed to elsewhere, perhaps. Folks have had or still have cancer. And is that disqualifying? Well, probably not. And they come with psychiatric and psychological problems. So it's quite a wide distribution of issues to at least think about. I put this together to help me explain to company management our thought process and on how we would go about getting to the point of saying or recommending, yes, you should fly, or no, you should not fly this customer. And it's really an iterative process. We start with an online medical questionnaire that's fairly detailed, review that and make a risk assessment, and that's where those green, amber, and red categories came from. Based on that information, we'll ask for additional information or additional testing, review that. At approximately 6 months prior to spaceflight, we'll ask them to undergo a physical examination. And since the customers come from all around the world, I think over 50 countries are represented now, it's not practical to try and get them all in one place to do the exams ourselves. And so we have enlisted the help of selected AMEs around the world to do those exams for us and provide that information. And so the results of those are again reviewed, estimate of risk reclassified, and mitigated to the extent that we can to get to the point of accepting an individual for flight. And I'll talk more about that acceptance process in just a minute. This is just a screenshot of the opening screen of the online questionnaire, but I put it up there just to show that it will cover demographics, general questions, current and past medical history, family history, female health history, exercise and activities, and body measurements. So it's fairly comprehensive. It's not the same as a 50-page initial astronaut selection questionnaire, but it covers all of the things that you would want to know for someone that is going to be undertaking what I call a passive flight. They don't actively have to do anything other than survive on the flight. And in terms of grading or evaluating that risk, we use two examiners independently looking at the data we have and making a risk assessment. And we created just an arbitrary 10-point scale of green, yellow, and red. And the goal is to move people as far to the bright green as you can with risk mitigation. One thing that has also become evident as we've gone along and been involved with customers in a variety of events is how do those medical conditions that they have impact operations? And they do in a number of ways. Training. What types of training are required prior to a flight? Does everybody need the same, or do you tailor it to individuals? You got to take care of them. So what do you feed folks? You have cultural differences to take into account. You have allergies to worry about. You have their sleep and sleep patterns to worry about. Some of them may be coming with a 12-hour circadian shift underway. How do you safely and comfortably seat them and restrain them in the spacecraft? What about egress? Not everybody is able to squat and jump out of an open hatch as easily as others. Folks are some quite elderly and don't move as quickly as they used to. Language barriers are always a concern, although the operating language is English, and the vast majority of the customers speak English and understand English quite well. Some don't. And even though you may get them through training to a point of understanding the basic commands, in an emergency, all that goes out the window. And we've had some part of one of the research projects that we just finished was an emergency a scenario in the centrifuge in which we simulated an emergency and asked people to follow a set of commands, and it was amazing how poorly folks could do in following a multiple set of commands when they thought that things were falling apart around them. So shifting gears a bit, I just want to mention the issue of integrating research with spaceflight. We have underway a pilot's study that Dr. Castleberry is heading up, in which we are wanting to look at cardiovascular response in 3 conditions. One is during acrobatic training flights. The second is in the centrifuge in a simulated space flight. And then finally to compare that with an actual space flight. Following on to some work that the Navy did with the Blue Angels team, because one thing that is unique about suborbital flights that we haven't had before is the high G, 3 to 4 minutes of 0 G followed by high G in about 20 to 25 minute period, and what that does in terms of things like the push-pull effect and the yes, there's lots of military pilots that fly inverted, and but they don't do that for 4 minutes at a time typically. So we're looking at that. Customer participation. 2 sides to that. One is customers want to know how they did. They want to come back and say, look, when that rocket engine fired, my heart rate went to 160 or 180 or whatever it did. So they want that information. Some of them are very willing to be test subjects as part of their flight, as long as they're not tied down and tethered with wires and equipment that is obtrusive. We want some in-flight data collection. We'd like to know what's happening to folks. And so we are continuing to test and evaluate new sensors, new technology that's coming out. It changes as fast as we can test things to get that in-flight data sort of in the background so it doesn't interfere with the enjoyment of their flight. And the other aspect to integrating the research with spaceflight is to take the data and the knowledge that we've gained from the research studies and translate that into operational implications for the operators, so that they can incorporate that into their training program development and into their procedures and cabin design. How are we doing on time? Okay. Talk a little bit about informed consent. So medical certification versus informed consent. Under the FAA's approach to the clearance for commercial flights, it is a licensing process, not a certification process. So the difference is, if there's a new Boeing 7X7 coming out, a tremendous amount of work and testing goes in by the FAA and by the company to flight certify that new airplane. Basically to say, yep, it works, it's safe to fly. That is not the case in commercial space flight. Operators are given a license to fly. The FAA does not certify that that vehicle is safe. They license the operation as against a set of requirements, certainly. And as part of that, each customer, each passenger is required to be informed about the risks and sign an informed consent. And both parties, the company and the passenger, have to both agree that, yep, we're willing to take you, and yes, I'm willing to fly in your vehicle, and only then does a flight take place. So part of that is the medical risk management. How do you define strategies and methods to assess and mitigate that risk and minimize the possibility of a bad event? So you've got to identify what those risks might be, figure out their implications. What is the company's level of acceptable risk? That could vary quite a bit from company to company. And so you need to, as the flight doc, you need to understand what the company's level of risk acceptance is and why, and what the limits are within that band. And then monitor as you go along. Because you're going to learn new things. You're going to find out, whoa, that really was pretty dicey on that flight. Maybe we need to back off a bit, or maybe we need to change training or change some procedures. So identifying new hazards, assessing the compliance with those, and measuring the effectiveness is part of that medical safety assurance. The ultimate goal, the ultimate outcome that you're shooting for is that you can identify and document the risks and the conformity with the requirements that you're working under, identify the new hazards, and then track your effectiveness in addressing that. It's also important that the safety culture of the medical safety component of risk assessment and mitigation is supported by, at the top level of the company. As I mentioned at the beginning, in the military, the flight doc can ground a pilot, but the CIO can override that based on mission requirements. The same thing could happen in a commercial environment. Probably not likely to happen, but it could. And so part of that safety culture has to be ingrained at all levels within the company, from senior management on down. And in order to achieve that, everybody needs to understand, have a knowledge base on which to make those judgments, and come to a common acceptance of what the risks are, because it's not zero by any means. And part of the medical safety culture is also preparation for the bad day. Emergency response plans are critical. It is not the time to start thinking about what hospital you're going to after the accident happened, and have that hospital totally unprepared to accept what might be coming their way. So the informed consent involves several components. As mentioned, the risk assessment. How do you communicate that risk? And how do people understand the risk as it applies to them? And then finally, accept that risk. And the individual medical risk that each person comes with based on their own medical history and current status is part of that. Communication of risk is a tricky thing. I put this up just to demonstrate the same set of circumstances can be presented in different ways. So if you look at the space shuttle experience with 2 vehicle losses, what is the risk of death? Well, it depends on what you choose for your numerator and denominator. If you use 2 accidents out of 135 flights, it's about 1.48%. If you choose 14 deaths out of 833 person flights, it's 1.7. But out of that 833, that represents 355 individuals, and so that risk could go up to 3.93. Or if you use risk of death in an accident, it's 100%. We had 2 accidents with 14 deaths. So how you communicate risk and how you help people understand what that means for them is important, and it's not necessarily an easy thing to do. So assuring that people do understand that and putting that in their own context so they understand what they're signing up for is further complicated by language and cultural differences. People may not understand the same words, English words, that we use in trying to explain what that risk is, depending on what their level of familiarity is with English. So they need to be able to understand it and then express back to you in a meaningful way what that means for them, so you have a pretty good idea that, yeah, they get it. And then again, risk acceptance is two parties, the customer and the company. Both have to understand the risks and both have to accept them before a flight takes place. So it's somewhat of a subjective process. The risk assessment is based on best estimates given the information you have. Yes, you use some objective data to help refine that assessment. Management and mitigation is critical, and the communication is a key part of that. And bottom line is there's a lot that we don't know. And we have to be honest about that in communicating the risk. Because for much of what we will be doing in the early flights, we will fly people for whom it's new. There is no data. There is no prior experience with flying an 88-year-old with heart disease, pacemaker, and hypertension, and assessing what that risk is. And so we're going to be learning as we go, and in many cases the answer is we don't know, but here's our best guess. So why is this fun? Well, for me, I get a lot of pleasure out of helping people make their dreams come true. It's also challenging and exciting to challenge the status quo, do things that haven't been done before. I've had a lot of my colleagues think that I was absolutely crazy when I flew with Stephen Hawking on the zero-G flight, including some of the folks at the FAA who said, "You're going to do what?" But it's also fun and interesting and professionally rewarding to be able to make an impact at all levels of the development and implementation of a new program. So what I tell our residents and applicants for residency is that this may be one of the most exciting times to be entering the field of aerospace medicine. We've got a whole new world out there, and there's a lot of opportunities and a lot of interesting things to do and fun to be had. So I think that finishes things up, and we should have about 5 or 6 minutes for questions. So thank you very much.
Thank you so much, Dr. Vanderploeg. It's an exciting new frontier that I'm excited for. So let's start with some questions. Do we have any questions from any of our satellite locations? A couple of potatoes. Okay, now we'll come in here to into the room at USRA. We have some questions. Dr. Stepaniak.
Yeah, thanks, Dr. Vanderploeg. A couple questions about this anxiety issue. Were these participants in flight suits, and were they helmeted in the centrifuge?
They were not helmeted. Some of them wore flight suits. We had some folks from astronauts for hire that came in their astronaut for hire flight suits, but they were in street clothes, basically.
Okay, and so they were not helmeted.
They were not helmeted.
Did any of them feel claustrophobic inside the centrifuge? Before, had a lot of anxiety before they entered the centrifuge.
Claustrophobia was not a complaint that we heard. The gondola of that centrifuge is quite large, and what is projected in front of them in an inverted dome is the interior and the windows simulated looking out. And so you don't feel closed in, and claustrophobia was not a complaint that we heard.
Just a suggestion, I don't know if it's reasonable or not, but I know some folks, they have a lot of anxiety because of maybe wearing a helmet and a mask. Mm-hmm. And maybe to try to preempt that, maybe to put them in a helmet and a mask initially to see if they would develop a lot of anxiety. Because I know folks who've gone through physiological training didn't like to, when I was a civilian, didn't like to wear a helmet and a mask, and they got very anxious about it. They felt like they were going to suffocate.
Right.
So that might be one thing you can do to maybe, preempt that anxiety. And then I don't know if claustrophobia, in the shuttle program, we had that sphere that we would put people in. And I think out of all the applicants that applied, I think there may have been 1 or 2 people that didn't pass that test.
Right.
And another question I know about anxiety and doing centrifuge runs. I remember those of you who've been in the military and you had to go through those F-16 profiles when the F-16 came on and how anxious you got for that. And I remember being out at Holloman and being very anxious about it because sitting in, with a bunch of F-15 and F-16 pilots, the first person who went through the run developed a G-lock and did the funky chicken. And once that happens, you become very anxious and you do not want to be on tape of doing that. Now, anxiety can be a good thing because it pumps you up and saying, it's not going to happen to me. There's no way I'm going to be on camera and videotaped doing this. So I don't know, were these folks videotaped? I'm sure you got a video cam inside the centrifuge to look for that. Is that correct?
They're on video. And part of the difference between the groups when we were looking specifically at anxiety is some of the groups got to watch the video of their other folks. Other groups did not. They had no idea what was coming. And so because we were trying to answer that question, does it help to see what the person before you has done and is doing, or is it best to go in cold? There's no right answer to that.
I agree, but I can tell you some level of anxiety is maybe good.
Yeah.
So you do not want to look like that.
That pretty well goes with the territory because everybody, including mine, and I've spun a bunch of times, my resting heart rate is about 20 points higher, as is my blood pressure, just before I get in the centrifuge than it is the day before. And that's pretty universal. It's an impressive looking machine, and knowing that you're going to get slung around the room at 6G gets your attention. And that anxiety is good.
Okay. Just one last question here about your training and the ability to do emergency egress and things of this nature. I remember a long time ago, back in the early 90s, and Dr. Jennings may know about this, that Congress came to us because there were certain individuals who were disabled, and they said we discriminated against the American Disabilities Act by not flying disabled people, that they were automatically rejected from applying as astronauts. So I remember Dr. Poole, I believe, the late Dr. Poole and Dr. Billick had to go in front of Congress and testify the need to do an emergency egress, and that's why we picked healthy individuals, selected healthy individuals to do this. Is the commercial crew program going to be prepared to be able to defend their rejection of maybe individuals with disabilities because of that? Are they aware of that situation? And that's all question I have.
Yeah, I think that question, the answer is different whether you're talking about the flight crew or you're talking about a passenger. I think the flight crew has to be fully capable of everything required, including emergency response, emergency egress. You may make exceptions for passengers who do have disabilities. I showed the extreme with Stephen Hawking, but there are many folks with lesser physical limitations that you probably can accommodate safely. But I would strongly speak in favor of it, although there may be joint replacements and artificial limbs and so forth for a flight crew. The military has demonstrated that can be done. But the flight crew needs to be able to be fully independently functional in all aspects to be part of that flight crew.
I think Houston Chronicle recently showed where I think it was Cooley who had a artificial heart patient, and they replaced the heart, and then the patient ended up dying from a pneumonia. I think it was published recently. They redid the story, and that the family actually ended up suing the physician, Cooley, I think it was. And you said this is a new realm for physicians to be working. When we function in NASA or in the military, we're functioning under our jobs and such. How do you? And you mentioned the liability and such. There are a lot of legal eagles out there that can turn around potentially, and with this higher risk group, end up putting people at risk. How do you personally, as a physician, keep protected? You're covered by what kind of insurance, or you're covered by what sort of relationship with Virgin Galactic, for example? What would you recommend for physicians going out into this field, what to think about when they're interacting with these kind of extreme environments and clearing people or making the medical recommendation for or against flight?
Yeah, very good question, and I didn't spend much time talking about that, but the personal liability concern for physicians doing this work is real. One of the reasons I'm at a state of Texas institution is that when you sue me, you're suing the state of Texas, and there's a lot of lawyers and a lot of money behind you. Buying private insurance on the commercial market to cover this is maybe problematic. The other answer, or parts of the answer, are yes, it's an informed consent. Now, people sign their life away and they can still sue you. Doesn't protect you, but at least there's that step in the process. The other is that, at least the way we've set it up within Virgin Galactic, I'm not making a medical clearance decision. I'm making a risk assessment that I provide to both the company and the customer, and they both agree to accept that risk. Does that offer some protection? Maybe. Doesn't stop somebody from suing you. So it's a new world. Richard, you may have some comments on that as well. You've been there and done that.
Well, I appreciate the comments, Joe. I think that is a big risk. We've always had the advantage, though, and which he doesn't have, of we put lipstick on the pig. We try to mitigate all the risk we can. We try to understand every problem and improve it and get it to the best that we can for flight. But the final decision on whether they're allowed to fly has always been through the international partners, not me. And there's a certain advantage in that. And it is changing now. Chuck and I, as you know, work some in certifying people, and now there's the new Appendix F, which is the follow-on to Med Volume C, and we're in the process of certifying people right now for commercial crew era under Appendix F, which NASA's and the international partners have put in, and it's an improvement. It's still too much. In other words, I don't think that someone's going to do a 10-day flight needs a magnetic resonance angiography of the brain, to be honest with you, but it's better than it was. But we've always had the advantage, and still even now with that, we still have the advantage of the certification final decision for CST 100, for example, will be NASA first and then the international partners. However, pretty soon, it won't be long, that's going to evolve where the CST 100 or the Dragon Rider, they're going to be flying to a freestanding vehicle, or they're going to be doing free flights, or they're going to be doing other type of flights, and we're back in exactly the same situation that Jim's talking about. It'll be, the physicians and the company, not NASA and the international partners. So, see, it's a good question. A lot of it to be determined, I think, yet, how that risk is going to be incurred.
We'll get one more question. All right, Dr. Bear.
So I know there's been a lot of debate on pressure suits, and you guys have opted not to do it. What about the conformational garments? The big disadvantages of those aren't applicable to you guys, which is joint deformability and movement. If you had a counter-pressure garment and some of the new lightweight helmets, you'd have a very simple interface, would allow you the freedom of movement that people would want to get out of their seats and see things, and really mitigate one of the biggest risks. When you look at the mortality, morbidity of spaceflight, it's probably not in those big 5 categories of disease you're looking at. It's those dynamic flight accidents, and that to me is one of your biggest risks. And you have a solution that is not practical for the rest of our spaceflight applications, but could work for you.
Yeah, it's an excellent point, Mike. And I think as over the last 10 years, technology has evolved and improved. There are now available some options that weren't before. And I think part of our job as the docs advising these companies is to say, have you considered this? And here's what our assessment is of the risk, and here's a way to mitigate that. It's still a company decision as to what direction to go, but there are, the world has changed and is continuing to change in what's available to mitigate some of those risks, and it's an ongoing process.
You guys do a pressurized leak check pre-flight?
Yeah.
How much pressure?
I don't know the answer off the top of my head.
I don't either. Okay, well, thank you, Dr. Vanderploeg, and thank you for those of you who joined us, and we'll see you next month in February. Thanks.